Hi everyone, welcome to the opening event of our Institute's Colloquium series, Trusting Science. I'm Stephanie Hood, I'm based in the Institute's communications team, and I'm really happy to welcome you all, familiar and new faces, some members of the Institute and also external guests today. So we will have several colloquia over the academic year on this topic of trusting science. And from this, we hope to facilitate some interdisciplinary dialogue around social, political, and internal trust and distrust in science. And the colloquium series will focus on both a longue durée perspective and on a local global scale. And from this, we also hope that we can provide some inspiration for further discussion and research. So I have a little bit of admin before we start. One is that we did plan to go for drinks afterwards. We've decided, because of the current situation with the pandemic, not to do that. And hopefully at some point, maybe next year, we'll be able to reconsider rescheduling an event. We will be recording the talk for publishing online and on our social media channels, but not the Q&A. So if you ask questions, you won't be recorded at that point. And I also wanted to thank everyone at the MPIWG who's been involved in organising this series. So our research group members, the administration, our library, and the communications team. So without further ado, I'm really happy first to welcome our Executive Director and Director of Department 3, Dagmar Schäfer, who will open this academic year's Institute's Colloquium series, and then who will pass on to our research group leader, Lara Keuck, who has organised today's colloquium on historicizing critiques in medicine. So thank you, Dagmar.
Thank you very much, Stephanie, and hello to all of you in this virtual world that seems so very near to us after 1.5 years of talking to each other via a screen. Trust is certainly one of the most central themes of the history of science, and therefore I'm really exceptionally delighted that such a collaborative group came together in this last year, or actually by the early this year, and established such a new and interesting Institute's Colloquium, where probably all the facets that you can find in this institute, in the building, as well as in the virtual space that is the Max-Planck-Institut of History of Science community, to think about what it means and how trust actually comes about in this particular field that we are all interested in science, technology, and medicine. I believe even if you only had a glance at the program, you will see that there is the potential for lots of excitement here, for inspiring new ideas about how to research this topic, and probably also even more room for more collaboration like this Institute's Colloquium really is showing. So I wish you all a very exciting Institute's Colloquium over this semester and the next one, and I very, very much look forward to today's presentation. And with this, I would like to hand over to Lara.
Much. Yes, thank you for the kind words of welcome, Dagmar and Stephanie. And dear internal and external participants, it's now my turn to welcome you all to this first session of the Institute's Colloquium. So my name is Lara Keuck. I'm a historian and philosopher of science, and I'm leading the Max-Planck Research Group on practices of validation in the biomedical sciences. We are interested in how assumptions, as well as objections to those assumptions, relating to health, disease, the medical system, validity, and other evaluative categories were proposed and put into use in the long 20th century. And against this background, we study when and how some forms of knowledge and uncertainty were legitimized and others were delegitimized. And I'm very happy to be part of this Institute Colloquium's team, because I think that there is a very interesting connection to these questions of trust in science. And I hope that we will discuss these relationships also within the course of the colloquium. Within this year, my research group will host 3 sessions. Today, we will start with historicizing critiques in medicine. In April, we will continue with historicizing trust in medicine. And in June, we will end with historicizing the reproducibility crisis. The speakers address historical continuities that impact public trust regarding the medical system, as well as trust among medical practitioners and researchers. And this topic, of course, also corresponds to other colloquium events that my dear fellow organizers, so this is a shout out to Ana Alas, Gerald Schmitz, and Pablo Ruiz de Olano, are hosting. So one recurrent topic is how historical privileges and injustices are bound up and covered in institutional structures. What are the origins and impacts of the predominant socio-epistemic structure of modern, in the case that we're looking at, Western medicine? Why are so many discussions regarding patients as well as physicians revolving around obligations of and towards the individual? And what roles have critiques played in the development of the contemporary state of medicine? So this set of questions is at the heart of today's colloquium. And we are very happy to welcome Caitjan Gainty and Ariane Hanemaayer as our speakers. They will each give a 20-minute presentation, followed by a brief discussion among the panelists before we then open the floor for general Q&A. So it is my great pleasure to introduce our first speaker to you now. So Caitjan Gainty is a historian of health and healthcare at King's College London. She runs the Healthy Skepticism project, which seeks to gain new purchase on the history of and contemporary of healthcare by taking seriously the perspective of its critics, doubters, activists, dispossessed, and other skeptics, past and present. She has recently finished her first book on the industrial origins of modern American medicine. Her work has appeared in a range of academic journals as well, and I think this is very interesting too, in more public-facing media, including the BBC, ABC Radio, Australia, Slate, The Washington Post, The Times, and The Conversation. So Caitjan, I'm very happy to have you here, and now the floor is yours. Just stop this.
Sorry, I was still muted. Thank you so much. I'm just going to share my screen. Thanks for that really kind introduction. And I'm really, really delighted to be here to talk on historicizing critiques in medicine today. And initially, my thought was that I was going to take this sort of in a very large sense and really think about healthcare discontent as it's been sort of, as it's come through in the 20th century. But I'm going to take just a very narrow and very empirical slice of that and think only about a couple of different themes of critique and show where these have come from. And I'm going to do that by drawing primarily on the US context. And the three themes that I really want to think about are personal relationships, or the doctor-patient relationship as this very critical piece of as part of what, how we evaluate healthcare. Access. So access is another really important way in which we think about whether healthcare is good or bad, and then effectiveness. And these three are sort of intertwining in the period that I'm talking about, which is the early 20th century. And probably the most important thing to notice about effectiveness, which I'll sort of table in this discussion a little bit, is that the kind of effectiveness that we now associate strongly with medicine is really not in evidence, and effectiveness is actually described in different ways. So I'm really kind of talking mostly about the first two, but those also have implications for this third, effectiveness. So just to kind of situate us, I think probably it's not really that surprising to think about access and doctor-patient relationships as important parts of the critiques of healthcare in our own contemporary. But just to give you a flavor of the kind of language around that, this is from the AstraZeneca website. And it offers this kind of standard language about the way that we think about access and the kinds of things we associate with it. And so, of course, one of those things is this idea that this is about offering healthcare to those with unmet medical needs and to reducing health disparities. And it's strongly associated with this notion, too, of health as a human right. So if health is a human right, then access to healthcare is sort of an important piece of the delivery of that human right in a sense. And so we get a sense of access as something that is really universal, or ought to be universal to healthcare, and also something that's relatively timeless, that just as health is a human right, this kind of idea is not something that's time bound in a specific kind of way. Access to healthcare also seems like it's just a kind of obvious characteristic of good healthcare. And the same goes in a lot of ways with the doctor-patient relationship as this quintessential therapeutic relationship. So what you're looking at here is the painting The Doctor by Luke Fields, which was painted in 1891. And the idea at the time, this was kind of a utopian depiction of what good healthcare ought to look like, that there ought to be this very attentive doctor. There ought to be the doctor in the patient's home, attending quite specifically to this child, and kind of sitting vigil, right? And that this is kind of the classic and the sacred, as is often said, doctor-patient relationship. And so over the period that I'll be talking about, but certainly also now, this painting has had a lot of purchase within kind of conversations about American medicine. So in 2018, we get this notion that this reflects the sacred nature of the patient-physician relationship, and also translates down to us. So we have more and more technologies now, but still the relationship needs to stay the same, because this too is timeless, it's universal. This is what makes medicine work in a fundamental kind of way. And where we see these two sort of coming at each other in an interesting way is in the conversations in the American context, of course, around Obamacare. So this is back in 2012. This is a congressman who's also a doctor, talking about why he opposes Obamacare. And his reasoning is that there are several very sacred relationships. One of the most special sacred relationships is that of a patient with their doctor, and offering universal access to healthcare, or anything coming close to universal access to healthcare, is going to violate or interfere with that relationship. So here we see these two narratives opposed to each other in an interesting kind of way, in a way that's actually not uncommon, and is probably one of the very familiar ways in which we see these two narratives arising. So where does this notion, so taking the sacred doctor-patient relationship first, where does this notion of this relationship come from? Well, in the American context, and also in the British context, it comes from concerns over income and the kind of payment systems that ought to typify medical arrangements. So the payment system that is kind of standard in the British and American context in the early part of the 20th century is a fee-for-service arrangement. And that fee-for-service arrangement allows doctors to charge what, as they say, what the market will bear for any of their services and from any of their patients. And that essentially means that the wealthiest patients are charged the most. And the way that price is determined is sort of by the services that are offered to these wealthy patients, but even more than that, by how they look, what they're wearing. And so it's quite a kind of an explicit and well-known thing that you charge somebody according to how wealthy they look, and you charge a percentage of that. And also that charge that you charge to the wealthy covers the care that you offer for free to the poorest of patients. And in many ways, in this kind of system, it's kind of the growing middle class in this period who don't have healthcare at all, and who can't afford to pay, but also aren't poor enough to be offered charity. So this is sort of the payment system of the period. And one of the big problems is that because there's so much competition in the medical marketplace in this period, that there are tons and tons and tons of choices when it comes to medicine. So not just the allopathic mainstream medicine that we have now, but also, chiropractic, eclecticism, osteopathy, all of these different kinds of medicines. And allopathic medicine is just one among many. So this is a period over which allopathic medicine, our medical orthodoxy, gains in power and turns kind of a competitive marketplace into a monopoly, their own monopoly. And the way that they have sort of a kind of three-pronged approach to this. But what they say as concerns sort of effectiveness in this period is that by stabilizing the incomes of allopathic medical practitioners, they are stabilizing the medical marketplace, which in turn stabilizes the wider marketplace of which medicine is a part, and that in turn stabilizes the economy. So one of their definitions of effectiveness in this period is this idea that medicine as a kind of part of the economy needs to be a stable piece in order that the American economy more generally will thrive. And there are many different aspects to this, but this is just sort of one example of the way in which they present their argument about stabilizing incomes in terms of this notion of effectiveness. And of course, it also changes what we think effectiveness means or what medicine is supposed to do in this period. So how do you do this? You contract the size of the medical marketplace, you streamline medical practices, and you quote unquote standardize the public's mind. So you do these kind of publicity meetings that move around the country and that get the public on board with this notion of only going to an allopathic medical practitioner and only paying in a certain kind of way. And this is where things start to run into problems. So the first of these, contracting the medical marketplace, is a relatively familiar thing. You drive out the quacks, which is anybody who's not an allopathic medical practitioner, and you contract the medical education programs in the first place, limiting those only to those allopathic medical programs that are deemed to be acceptable. So you lower the number of physicians that there are sort of in total, which in turn increases and stabilizes income. The other thing that happens, and this is a picture of the Henry Ford Hospital, is increasingly this notion that medicine should mirror sort of the industrial enterprises of the period. And so at the Henry Ford Hospital, they adopt this kind of assembly line approach to patient care, where effectiveness is really sort of a synonym for thorough processing. So what happens is you go into the Henry Ford Hospital, you're looked over, you kind of move through the hospital in a regulated way. You're looked over by a variety of different practitioners, each at a different body system. And then you are given a diagnosis and possibly a treatment plan and sent on your way. And the guarantor that you have had effective medical treatment is in the fact that you have been thoroughly processed. But the objection to this is quite strong. And so those outside of the Ford Hospital talk about this as a kind of violation, again, of the doctor-patient relationship. So they liken the Ford Hospital to the Ford assembly line. They liken the patients there to flivvers, which is a colloquialism at the time for the Ford Model T. And they say that these kinds of practices are taking the kind of therapeutic relationship out and taking the person out of care. And that would all seem sort of reasonable and really kind of goes with the kind of, kind of way in which we talk about these things now, except that the Ford Hospital had taken all of this from the Mayo Clinic, and the Mayo Clinic was celebrated for its thorough processing rather than being excoriated for being an assembly line operation. And so here, the effective care notion is allowed to stand. And the difference between these two is, of course, in terms of fees. So at the Mayo Clinic, the fee is determined in sort of the old-fashioned way, where everybody is assessed according to what they're wearing or what their income looks like, and then they're charged on that. And at the Ford Hospital, everybody pays the same. So it's a flat rate per procedure. And also the salaries are all structured and set. And what the Medical Association in Detroit and other places where this is happening, what they object to, in fact, is not the loss of the doctor-patient relationship, but the loss of a certain way of fixing fees. And so they use this kind of becomes this doctor-patient relationship really becomes a way of glossing a particular concern about how fees are assessed and how income stabilization will take place or won't take place, depending on sort of, the view you take of these different sorts of interventions. And so what we end up with is this opposition by the end of the 1920s, which really sets in contrast and creates our sort of contemporary contrast between, on the one hand, this very personal therapeutic relationship that the doctor in Luke Field's painting is having with his patient, and on the other, something like the kind of farcical, industrialized vision of the world that comes in the Charlie Chaplin film Modern Times. So this is an image of him being sort of subjected to a feeding machine, an industrialized feeding machine, where everybody moves through these things as though they are just sort of bodies on an assembly line, or they are sort of having things done to them, but they've lost their personhood, and they've also lost the very thing that made healing possible in the first place, which is a real relationship with their physician. And again, this is of course exactly the same kind of thing you see, and we've seen around this in the U.S. context around things like Obamacare, the Affordable Care Act, and this concern over, well, what does state medicine actually ultimately entail? Well, clearly it entails this notion of kind of industrialized care, or the intervention into the doctor-patient relationship, into this caring doctor-patient relationship. So added to this is this other little bit, which is this kind of standardizing the public's mind idea, in which increasingly over this same period, these community health meetings are held, which really bring up this idea that medical health must be, or medicine to be effective must be personal. And the way that they do that is quite specifically through the disease, through cancer as the kind of paradigmatic disease. And the idea is that if health is personal and not public, then, and your responsibility is for your own personal health, then you need to go to the doctor all the time, because you never know when cancer might strike. So you might have cancer already, and if it's at the beginning, then it's easily curable, but anything past that becomes really problematic and at the end completely hopeless. And so they use this as a way to kind of not only increase the number of interactions that you have with your doctor, but also press home the point that actually the way of the future is personal medical care, not public health interventions more largely. And all of this feeds into this notion that, and our contemporary notion that these doctor-patient relationships are critical, but also that this is a personal, that health is always a personal thing. It's never a community or a state or a global kind of thing. So what happens is that we leave the 1920s with this doctor-patient relationship narrative, it really intact and opposed to this notion of industrial care, and enter into the Great Depression. And what happens in the Depression is, among other things, the introduction of the welfare state, and this welfare state is in the habit of kind of saying like, well, these are the basic needs of citizens, and we need to provide for those needs in some kind of way. And because the community health meetings and all of this kind of publicity around medicine has produced medicine as this indispensable thing that each person needs just as much as they need housing and food, it starts to get added to the agenda of things that the welfare state is supposed to distribute and is supposed to be taking care of. And so this brings us to this question, or this new issue of access. So in the 1930s, this working group on the Committee on the Cost of Medical Care produced this document called Medical Care for the American People, where they essentially argue that because medicine is such an indispensable thing for each and every person, then every single person therefore must have access to medical care. And in a way, they flipped the script on what the medical orthodoxy has been saying all this time in order to drum up patient clients. They've been saying, like, you absolutely need this personal medical care. And they've taken that and they said, well, if that's really true, then we all need it. And really the thing we should be focusing on is access. And who's able to produce access like that? Only the federal government, not the American Medical Association. And they, of course, oppose this idea of access, of universal access, by saying that this is going to intrude on the doctor-patient relationship, not only because it's somebody else coming in and doing kind of the money work, but also because it's going to ruin this therapeutic relationship, and people are not going to be as healed as they would be otherwise. And these are two quotes from two progressive physicians who held the opposing view, who said that, who sort of called foul on this by saying that, it's quite clearly that wealthy patients will continue to have their therapeutic doctor-patient relationship. And the only thing we're saying here in terms of extending medical access is that those people who have never had access to a medical practitioner will now also be able to enjoy this doctor-patient relationship. And then on the other side, saying like, well, isn't it also the case that if you're going to have a good therapeutic doctor-patient relationship, you would rather not have to deal with the money, right? You would like to have this relationship based on trust and sort of therapy, and not on the fact that, not on the amount of money that this patient is going to give you. And so really they're sort of, calling out the medical orthodoxy for on their own rhetoric, and kind of turning it around on them and saying like, actually, isn't this an argument in many ways for access? And this has been sort of a state of affairs in the US context, again, for a very long time, that these two things are in many ways in opposition. So here is some campaign propaganda that the American Medical Association put out in the 1950s, which was the next time that a nationalized health service was on the table. And they used the same Luke Fields painting, and they once again presented as this idealized doctor-patient relationship, and say that a nationalized healthcare plan is going to interrupt and intervene in this and ruin your therapeutic relationship. And by this time, instead of saying, well, we demand a fee for service, they say, well, voluntary health insurance, it will keep politics out of this picture. Politics is the thing that's going to ruin it by injecting this kind of industrialized, standardized, but also interventive kind of wedge into the doctor-patient relationship. And so this kind of historical context really helps us to kind of situate both access and the doctor-patient relationship, these pieces that we take for granted as the right kinds of critiques to offer of healthcare systems. And in fact, I teach a class that's about the comparative history of the US and UK healthcare systems, even though they're really not that comparative, but rhetorically, people seem to like it. And those are the first two things that they say. Well, the NHS is a much better system because it offers access, and access is an obvious good. And also, in another vein, the doctor-patient relationship is the thing that makes medicine therapeutic. And only third on this list is effectiveness, which I think is an interesting thing. But this historical context, it not only tells us a little bit about where this rhetoric comes from, but I think what it helps us to do is kind of get out of the loop that we've been in for a very long time, because really, essentially what's happened is, the kind of the American Medical Association, in the case that I'm describing, produced a particular kind of rhetoric for their own purposes, and then sort of fed it out publicly. And then it was embraced by the public, and then it was fed back into medicine, as though these two pieces of these two evaluative, pieces are the right way to evaluate a healthcare system. In fact, there are lots of other ways, if we could sort of break that cycle, to evaluate healthcare systems. And one of the things that I think has been a real and obvious negative effect, because in general, it's hard to say like, well, access and doctor-patient relationships are actually terrible, and I don't believe in them. Of course, that doesn't make any sense. But one of the things that this hopefully would help us to think about when historicizing this critique is that, especially in terms of access, those healthcare systems like the NHS used access as a way to kind of restore equality within a healthcare service. So the idea was that giving people access is going to make more equitable, healthcare more equitable. And what they actually found already by the 1980s, so remembering the NHS comes in 1948 also as part of a kind of a welfare package. By 1980, they found that actually inequalities in healthcare in the UK had increased, not decreased, with this universalization of access. And so that should really tell us something about how we might want to kind of tweak our critiques in order to really kind of think about, well, what is it that we want to value, or what is it that we value about healthcare? But instead, we've continued, nevertheless, in this vein of talking about access and saying like, well, universal access automatically means that, you know, things are better. But we could also be talking about, you know, equality, or we could also be talking about other kind of various pieces of healthcare that we might actually value more. And so one thing that this historical context might add is this kind of prompt to think past these particular frames of reference, and think about what else could we critique, or how could we rethink what we really are looking for in a good healthcare system. So I have more to say, but I'm going to stop because really it's Ariane's turn. So I'll stop there and stop screen sharing.
Thank you so much, Caitjan, for this very rich talk. Yes, I hope that we will continue this discussion very soon. So thank you for showing us how personal relationship access and eventually effectiveness were solidified as legitimate critiques of medicine. And I think this brings us immediately to our next speaker, who will continue with the topic of effectiveness and the institutionalization of the science of effectiveness in her contribution. So it's my great pleasure to introduce Ariane Hanemaayer to you. As you can already see in her pronouns, she's from Canada and multilingual. So Ariane Hanemaayer is a sociologist of knowledge. She's associate professor of sociology at Brandon University, visiting fellow at the Center for Research in Arts, Social Sciences and Humanities, so CRASH, at University of Cambridge, visiting scholar at IGNIS, the Center for the Study of the Life Sciences at the University of Exeter, and also a visitor in my research group, actually until the end of this week. So if you want to meet her in person, you can still do that. So Ariane is the author of the book, The Impossible Clinic, A Critical Sociology of Evidence-Based Medicine. And her forthcoming book is entitled The Impossible System, A Critical Sociology of Public Health. She's also the editor of AI and Its Discontents, Critiques Across the Humanities and Social Sciences. And this gives me also the opportunity to thank the library for providing all the publications of Caitjan and Ariane, and you can find them in the virtual bookshelf. But now, Ariane, the turn is yours.
Thank you so much for that great introduction, and for Caitjan's talk, which has just been, I have just scribbled so many ideas while you were speaking. So I'm looking forward to the conversation later. And thanks so much for inviting me. So I'm just going to jump right into it. I'm assuming that you can see my slides now. Perfect. Excellent. So today I'm going to talk a little bit more about effectiveness. And I want to explain how this kind of method of critique, or the critical appraisal, became institutionalized, but also what I see as its consequences. So kind of piggybacking on some of the questions that Caitjan left us with. I'm going to start by talking about how medical authority and medical reasoning came to be questioned, how this led to a science of effectiveness, and then how that science moves into the clinic, like how it proposed to reform what it was that doctors were doing. And then the fourth section, which I call the eternal return of the same, which is a way that the same questions continue to come up. So there's a kind of foreclosing that happens in how it is that we can offer critiques of science, either from within or from outside of the clinical sciences. And I'm just going to conclude with a few questions. So the first section here. All right. So according to the British Medical Journal, giving soapy enemas to people during labor prior to childbirth was a common medical practice up until the 1970s. Persons giving birth were frequently subjected to this procedure on the basis that it was good for the parent and the baby. Parents would not have to worry about leakage from their back passage during childbirth, which could be, according to conventional wisdom, embarrassing for them. And the additional benefit, medical professionals thought, was that during delivery, newborns could be protected from the slight chance that they could come into contact with harmful bacteria contained in the excreted stool. So while we might be suspicious that the rationale behind the birthing person's possible embarrassment isn't really a medical justification, we might, though, lend some credit to the aspects that concern the health of the baby. The procedures were, as you might imagine, quite painful, very uncomfortable, especially given the fact that they were administered during childbirth. But how was it that someone giving birth could refuse something that's told to them as being good for the baby? So what is the basis that anyone could question this medical procedure? So scientific analysis comes to the rescue here. Clinical researchers started to conduct a review of the literature to assess what they could find about whether enemas were really beneficial or not. And the authors published their findings. They said, these studies found no significant differences in any of the outcomes, either for the woman or the baby. However, none of the trials assessed pain for the women during labor, and there was insufficient data to assess rare adverse outcomes. Thus, they say the evidence speaks against the routine use of enemas during labor. So by testing whether enemas were or weren't improving the outcome of newborn and mother health, the researchers found that this practice was not effective. They recommended that this thing that had been done quite commonly for a long time, that was believed to be important in the medical profession, they argued that instead it should be stopped. So what doctors were basing their judgments on before this, right? What were they basing on before this? If it was now the case that science was showing that this procedure had no medical benefit, and if science could disrupt these conventional ideas, could it also be used to correct and improve reasoning in the clinic? So questions of this nature are attributed to an approach that would come to be known as evidence-based medicine, which I will discuss later. So just briefly, I want to say that my work synthesizes the corpus of Michel Foucault in order to generate a genealogical analysis of the literature. And in my case, I'm actually focusing on World War II onwards. And I'd be happy to discuss that more in the Q&A if people are interested. In general, I'm curious about the epistemic structures, or what Foucault calls the relations of discourse, that provide the conditions of possibility for rendering something as scientific or not? Or how is it that there are certain rules that tell physicians in their reasoning that something is true or false, is a good thing to do or not? And how can we say that this is based on science? And as we'll see, that this particular scientific rule of effectiveness comes to problematize clinical judgment. So how this happens, especially after the Second World War and leading into the 1960s, is first articulated by someone named Alvin Feinstein. Now, what Feinstein writes about in his book Clinical Judgment is an experience working on. So he's a part of this medical study that's testing for rheumatic fever, and in the study, he's listening to the heartbeat of his patient, right, as he's doing these investigations. And he's trying to determine whether there's a murmur, because recording that clinical symptom could then be an indication of this illness, of rheumatic fever. So while he's listening to a patient's heart, he writes that he hears this faint murmur that hadn't been recorded in the patient's medical history. And he realizes that if he hadn't heard it, that would affect the patient's life in the future. And he also had this moment where he realized that he might have made similar mistakes in the past, right? Maybe there are other patients that he had not of a similar murmur. So Feinstein associated this problem with the nature of clinical judgment itself, and he set out to eliminate the variation that resulted from one physician's interpretation of the symptoms on the patient's body. And so in his book, Clinical Judgment, he writes, what choices would doctors really be confident about? Honest, dedicated clinicians today disagree on the treatment for almost every disease, from the common cold to metastatic cancer. Our experiments in treatment were acceptable by the standards of the community, but they were not reproducible by the standards of science. And so now let's think a little bit about how it is that these standards were established through a new science of clinical epidemiology. So Feinstein goes on to how it is that clinical judgment might be something that can be leaned upon, that can be studied, that can be reformed. And so he says later on in this same book, the intellectual technology of clinical judgment, or the method of inanimate methods for observing and assessing tangible materials. So there's a number of different things that happen at this time. So he's told us that we really need to be dedicated to thinking about a systematic way of approaching clinical judgment. And at the same time, a number of things are happening in the profession of medicine. New methods are gaining prominence around this exact same time that a new science of clinical epidemiology is being established. One of those things, of course, is the randomized controlled trial, which was developed from the late 40s and over the 1950s. And these trials are designed to inform clinicians on the best outcomes of treatment by comparing a control group, those people who don't receive a therapy, with the patients who do. And this method could then track whether drugs are efficacious for particular populations, and using methods of statistics could then determine whether something is actually effective at treating an illness or not. Additionally, there were new databases being developed that house these randomized controlled trials and their outcomes. For example, in the United Kingdom, the Oxford database of perinatal trials was the first database which contained a collection of randomized controlled trial studies that were in the obstetric field. And this was written in accessible language for non-specialists. So the idea was that anyone with a medical degree could read it. And on top of that, they made a separate manual that could be shared with patients. So patients could also become knowledgeable about what those best practices are based on that same type of randomized controlled trial evidence. And finally, at this time, we see the emergence of the Journal of Clinical Epidemiology. So it actually becomes a specific field in medical practice. So as this field is being developed, we have the emergence of a kind of new specialty of clinical epidemiology, which is described by Sackett in a new role. And this role joins not only research and science of effectiveness, but also the in-clinic activity. So he describes the clinical epidemiologist as an individual with extensive training and experience in clinical medicine, and also epidemiology and biostatistics. And the whole point here is that even once you've gained this knowledge of epidemiology, statistical understanding of research design, you also continue to provide direct patient care. So this new role brings together research and clinical intervention. But if physicians are supposed to use evidence, that means they have to know where to find it and how to interpret it. So over the 1980s, a number of textbooks start to emerge in medical training that are designed for students to help them learn those ways of reading and interpreting evidence. Sackett, the person I just quoted, and his colleagues wrote a book titled Clinical Epidemiology, a Basic Science for Clinical Medicine. And this textbook aims to teach people how to research clinical care. So these types of books provided a solution to this problematization of judgment. We can educate individual clinicians so that they can bring together that scientific evidence with their clinical expertise. This method is termed the critical appraisal. We've just arrived. And this notion of critical appraisal was coined by researchers at McMaster University in Canada. And they located the site for institutional interventions in clinical reasoning. They say critical appraisal comprises the ability to assess the validity and applicability of clinical, paraclinical, and published evidence, and to incorporate the results of this assessment into patient management. It is based on the premise that to be effective in maintaining or improving the health of their patients, clinicians must base the care they give on sound scientific evidence so that it does more good than harm. So critical appraisal as a method is aimed to empower physicians to adjudicate the science for themselves and to better inform their clinical decision-making. The method focuses on questions that they have in the clinic, right? Like, I want to treat patient X. I will go to the literature and find the best possible treatment. And this allowed physicians to understand the types of risk for different therapies, the methods that they can use in the clinic, but also to bring that knowledge as it happens, as it's developing outside of the clinic, directly to the bedside. It's a way of what some physicians have called systematizing clinical judgment. So the appearance of critical appraisal in these international journals, this is going to serve as a final example before I move on here. So Gordon Guyat is one of the members working with Sackett on this new method of critical appraisal, and he also is a part of the evidence-based medicine working group. And in 1991, he publishes for the first time a connection between this notion of evidence-based medicine with this method of reasoning. The article here that this quote is from, it begins with a vignette, a physician who wants to understand the diagnostic properties of a test, its sensitivity and specificity, and who wants to understand how to search the literature and apply this knowledge to an individual case. Here, for the first time, the method of critical appraisal and evidence-based medicine are brought together. He says, for the clinician, evidence-based medicine requires skills of literature retrieval, critical appraisal, and information synthesis. The term evidence-based medicine comes to replace the critical appraisal method. Guyat makes clear the importance of this method in improving the future of medicine. The way the future is described here depicts an important advance in the inclusion of new evidence here. He says, clinicians were formally taught to look to authority, whether a textbook, an expert, lecturer, or a local senior physician, and that this is how they're supposed to resolve patient management issues. Evidence-based medicine uses additional strategies, including quickly tracking down publications or studies that are directly relevant to the clinical problem, critically appraising these studies, and then synthesizing and applying these results to the clinical problem at hand. And so evidence-based medicine comes to represent this conscientious, explicit, and judicious use of the best evidence, which are these randomized controlled trials, and then synthesizing that knowledge with the clinical evidence of the patient in front of you. And this is exactly how it sort of emerges from this question of clinical judgment, and it comes to shape what kinds of practices count as good science, good clinical reasoning, but also how it is that we could question conventional practice, as I mentioned earlier. So just to move towards the conclusion as I close in on the 15-minute mark here, is that this revolution of critical appraisal, of evidence-based medicine, continues to be problematized, right? There's so much evidence. There's so many controlled trials. How is it, physicians started to ask in the 90s, that we're supposed to keep up with all of this information? Additionally, concerns about how to synthesize that vast amount of information in the clinic start to be raised in the literature in the 90s as well. So the solution proposed there are these evidence-based practice guidelines, which are supposed to be generic decisions that can then help the practitioner who doesn't have time to read or do that critical appraisal to just follow the right steps in order to treat patients in the clinic. Now, guidelines are created collaboratively, often between various stakeholders in healthcare, including patients, and they're meant to provide this systematic framework for not only action, but also what evidence counted to begin with. And these things are endorsed by medical associations in Canada, in America, in the United Kingdom, and elsewhere. And they also, as I showed in the Impossible Clinic, they come to play a role in disciplining physicians as well. What about the patient, right? We've focused so much on questioning medical authority. Well, the question about patient values continues to resurface over and over in the conversations around the role of evidence in clinical decision-making. And patient values are just one example of how there's been an ill fit between the dominant way of doing clinical reasoning and what it is that patients may prefer or what they value. So patient-centered care is one of these ways that people have attempted to shift the focus to the patient, but also as a way of trying to provide them the necessary information of clinical effectiveness in order to support their own choice when they're patients. But the concerns in the literature that continue to resurface have to do with the fact that it's quite difficult to quantify patient preference. It's difficult to quantify patient values. How would one make a subjective determination about the value of their own, say, mobility, their own lives, and then put that into a framework that makes sense when we're talking about statistical modeling of populations and what is effective for particular patients from those populations? So there's a constant return to the question about how physicians should interpret that new evidence, the patient's values and preferences, within this broader logic. How is it that they should use that critical appraisal to synthesize these new forms of evidence when the dominant evidence that's supposed to guide their decision-making for guidelines, as well as critical appraisal, is predominantly these massive population studies? So I want to conclude by saying, yes, evidence-based medicine provides this excellent rationale for how we should think about clinical judgment, for how we might question established dogmas and practices in the clinic, but also how patients might also come to their practitioners with their own understanding of what it is that they potentially want or what it is that they think is the most effective treatment. It has standardized medical education by providing a kind of systematized way of synthesizing evidence, and it has also standardized the professionalism and competence of medical practitioners in a number of nations as well as others. But I want to leave you with these questions here, which is that the further that we have continued to focus on the individuals in the clinic, the patient, what their values are, how to quantify them, or the practitioner, how do they use evidence, how should they, how can they keep up to date? The less then that we focus on the structural conditions that matter, that shape that clinical interaction to begin with, such as healthcare infrastructure, health disparities, which I love that Caitlyn brought that up, as well as representation and other forms of evidence that might very well have been excluded by this dominant framework. So we might ask ourselves if this is the kind of clinic that we want, and how it is that we might more adequately participate in reshaping these logics and frameworks that have come to guide our healthcare experiences. So thank you.
Thank you so much, Ariane. Yes, this was wonderful. And before we open the floor to questions from the audience, we want to address some common points of discussion. So I think what is really striking with both of your presentations is that you're looking at the history of critique and how it moves from outside critique to inside critique, or the other way around, right? And you yourself are also situating yourself, right? So you're not only critical observers, but also kind of engaged scholars. So I'd be interested in like both of your conclusions with like the refocusing of critiques that go into another direction, and how you make the relationship between this history of critiques to the topic of like trusting science, right? So what can we learn about trust, or how can we refocus perhaps that discussion as well when we look at what you told us in your two great talks?
Shall I go first and say, yeah? Okay, sorry. Ariane, I thought that was really tremendous. And I love the questions that you ended on. Is this the clinic that we want? I think that's, exactly the right question to be asking. But kind of thinking, so tabling that for the moment and thinking instead about how this history of critiques sort of, how does it sort of move into this question of trusting science? I mean, one of the things, and as an engaged scholar, one of the things for me that's been really important is kind of thinking about evidence and effectiveness actually much more. So for me, like the idea of historicizing critiques like doctor-patient relationship and access really has to do with the sort of kind of circularity of these discussions, that we can't ever sort of pull ourselves out of that to be able to kind of evaluate medicine as something other than in those terms. And I think that that has really been kind of to the detriment of much wider, broader conversations that in many ways the pandemic has raised for us about how medicine actually works, and exactly whether this is how we want it to work, and whether the kind of trusting that's implied in these kind of very familiar terms of access and doctor-patient relationship and evidence are really the terms that actually do hold our trust. Is there sort of another reason why we trust science that we could sort of get to by lifting away this veneer, the way in which we kind of construct this trusting relationship in the first place. But for me personally, I've been working kind of thinking about how to apply these things in practice, and working with a community in Brixton on this shared project that has very much to do with evidence as a huge problem. So for them, it's a predominantly Black community, Caribbean, from the Caribbean, from different parts of Africa, a very mixed community in that sense. But one of the features that they hold in common is this idea that evidence is always being extracted from them, that evidence is an extractive sort of enterprise, and that evidence, this kind of evidence-based medicine or evidence-based sort of world that we live in, is really not a world that's about evidence at all, but is about a kind of world that just recapitulates the same kind of privilege, the same kind of relationships that capitalism sort of predicts in this kind of larger way. And so one of the things that we've been working a lot on is to say, well, what else counts as evidence, and how else might we build? What else could we add to the mix that would help to, if we decided that an equitable healthcare system is the thing we wanted more than anything, what are the ways in which we could build that equitable system through, kind of rethinking evidence? And so for me, that's been it's a very sticky and difficult problem, because as we've said in previous discussions, it's kind of this, like, do you want to reform what's there, or do you want to blow it up? And really, I think the community wants to blow it up, because all of the values that are implicit in the way that we think about and think about evidence, and also the ways in which we trust science, really don't apply in their case. And so we start to see this kind of tension between equitable healthcare, or sort of equitable healthcare and the healthcare systems that we have, sort of more largely. But I'll stop and turn over to Ariane.
Oh, that's so interesting. I want to hear so much more about your Brixton crew. That's amazing. Just to kind of come back to the role of critique, and okay, I'll try to focus on 2 points. The first is that the way that I see myself situated is that I want to provide these alternative ways of viewing how we got to now, especially with respect to the conversation around the clinic, or in the more recent book on like public health policy, which tends to focus on the actors, like who are the people there in the moment, and how is it that we should get them to do something differently. And I think that this question has become a bugaboo for me, keeping me up at night in a lot of different ways, because I think that the more that we individualize the issue, what's happening behind the scenes is the further retrenchment of support of the infrastructures that are needed where those actual actors are doing the things that they're doing. So I think I want to play a role in kind of thinking about how is it that we should trust science, but also within a context that the sciences themselves are being utilized in particular ways to support that same disinvestment in infrastructure, right? I think like, you know, having lived through the pandemic in the United Kingdom while I was finishing this book on public health, is that the constant, you know, things that were written on the side of buses, right? Like hands, face, space. And only you can save the NHS. And so the kinds of ways that public health informed policy was that it became a matter of individual behaviors. All the while, you know, Boris Johnson's government is making cuts to a healthcare system that's already at its limit during a global pandemic, right? So I think that the thing I want to offer in kind of doing that work is thinking about, okay, how is it that these kinds of sciences are used, even when people are having really important conversations around health behaviors like mask wearing, hand washing, and etc., but also thinking about what kinds of worlds or what kinds of institutional and governmental structures are using that knowledge in order to serve their own kind of ends or their own interests. And I think that that's kind of what I'm hoping to add to that conversation. But I wanted to just, for my second point, just briefly pick up on the questions about what kind of evidence we want. And this is one of the kind of more new projects that I've been thinking about around how is it then, how do we build it, right? Like, you know, if you build it, they will come, like this, you know, old school baseball movie reference there. But the idea that if we actually produce the kinds of evidence repositories that could then be used, whether they be by regulators or practitioners, that then itself could potentially work within the framework that we already have. And I'm trying to do this now with a group of a great team around rare disease, because you know, we're moving through precision medicine and genetic medicine more into this world of, you know, even cancer now is considered a rare disease because you can sequence the tumor, you can sequence the mutations, and then that becomes particular to you, to the individual person. And when you start looking around, there's may only be maybe like 10 people in the world who have a similar mutation that you do. And so we might think about, okay, how is it then we might need to use a drug that has never been approved for this therapy, like an orphan drug, right? Something that we might relabel for this small group of 10 people. Well, what regulators are already doing is they're asking the patients themselves. So they're already using new forms of evidence at the level of regulation and health reimbursement, like in Canada and the UK. They're already using that kind of qualitative or testimonial evidence. But they're still doing it through an evidence-based kind of framework, right? So there's a kind of unhappy marriage that's happening. And so one of the things that we've been thinking about doing, you know, with this team is actually building that repository. Like, what would we want that to look like? We're in early stages, so if you ask me, I don't have an answer yet. But this is certainly something that I think is a kind of collaborative effort, not just from the humanities, not just from the social sciences, not just from patients and patient movements, but also from the regulators themselves who are being faced with these decisions where they have to merge evidence without a framework. And of course, the practitioners who really want to help the patients that are sitting there right in front of them. So I think working together to build new infrastructures and new mechanisms is, I think, potentially one way that we can start to undo the system as it is now, as it's been, you know, provided to us, or as we've inherited it. And that, I think, to me is like, it's the small moves that then we can start to push back. That's my optimism for the day.
Yeah, thank you so much. I think we could go on for a much longer time. But the good thing that I want to announce is that we hope to bring both Ariane and Caitjan back next late spring or summer, hopefully when traveling is possible again. So you can have a chance to meet them again and we can continue this rich discussion. Let me thank again very much Ariane and Caitjan.